Hello, everyone. We have lots of fans of our guest speakers entering the room, so pardon us while there are hugs going off in this corner. It is my pleasure to welcome you to our final grand rounds of the academic year. We'll be talking today about serious illness accompaniment, the End of Life Option Act care at UCSF, and we are blessed to have three very distinguished clinicians here who do support the End of Life Option Act at UCSF and who have been instrumental in making it work for our patients. So it's my pleasure to introduce Dr. Breeze Bell, who is an assistant professor in both the Division of Palliative Medicine and in hospital medicine. She also serves as the medical director for the End of Life Option Act and has really fulfilled the goals of that role of making the process easier for both patients and clinicians, and has built a lot of layers of support for that process here at UCSF, for which we are very grateful. She did her internal medicine residency at MGH and her fellowships in palliative medicine and integrative medicine here at UCSF. We're delighted to have her. She's also joined by Eve Cohen, who's a palliative care nurse and the program coordinator in the UCSF Palliative Care Clinic, but holds many hats and really holds our outpatient palliative medicine clinic together. And she focuses on how do we maintain our quality of life for patients with serious illness. Eve earned her bachelor's degrees in nursing from Johns Hopkins University and has also worked with patients with HIV, AIDS, and those in hospice care. Lastly, but certainly not least, is Teddy Scheel, who's a social work supervisor at the Helen Diller Family Comprehensive Care Center. He co-manages the oncology social work department and works as a palliative care social worker within the Division of Palliative Medicine. He earned his master's degree in social work as well as a master's degree in public health at Washington University in St. Louis. And before joining UCSF, he was a social worker in the emergency department at Barnes-Jewish Hospital. So we are thrilled to have these three clinicians here to really demystify the End of Life Option Act at UCSF and help provide tools for us to navigate this safely, as well as tell us a little bit about the history of the act and how it's played out over time. So delighted to have these three folks with us. Welcome you to the podium.
Thank you, Michelle, for that kind introduction. And we are so honored to be here with you today. Thank you, everyone who is able to make it and who can join us also virtually. These are just a few of the headlines that have been published in the media recently about medical aid in dying just in the past few weeks. As you can see, this is becoming an increasingly popular topic to discuss, not just in the medical literature, but also in the lay press. In addition to many informational articles, it's also easy to find several opinion pieces that really run the gamut and are very strongly held views on all sides of this issue. So we thought it might be helpful to begin our talk today by acknowledging and naming that talking about end-of-life care, and particularly talking about aid in dying care, can sometimes be difficult. It can bring up emotions about this aspect of our work, and it can bring up ethical questions and concerns. So we thought it might be helpful to share some personal stories about why each of us engages in this care in our professional work and how we came to it. Like many of you in the audience today, I chose a career in medicine to help my patients heal. In the best of circumstances, that means being able to offer curative interventions that allow our patients to be free of disease. In many other circumstances, it means offering interventions that allow our patients to live longer and better with chronic conditions or incurable conditions. As I went through my medical training and the early years of my career, however, it became unavoidable to me to acknowledge that, unfortunately, our patients do die, and there are some illnesses that they suffer from that are beyond the frontiers of our medical knowledge, and that sometimes cause tremendous suffering at the end of life. As a physician, it's incredibly important to me to accompany my patients and their loved ones at all stages of their health journeys. And that's why I chose to pursue specialty training and a career in palliative medicine, in addition to internal medicine. And increasingly through that work, a subset of my patients approached me about their wish to pursue medical aid in dying. This is their legal right here in the state of California if they meet certain criteria, which we'll get into later on in this talk. And it became extremely important to me to ensure that my patients who wish to pursue this option were able to do so with the same gold standard care that we provide in every other aspect of their medical care here at UCSF. So with that in mind, I got involved in quality improvement work in the End of Life Option Act space here at UCSF in 2022. We'll talk a little bit more about that shortly, but ultimately this led to a medical director role, which I have fulfilled since 2023. I'll turn it over to Teddy.
Yeah, and to put it quite simply, as a social worker, I believe in every patient's right to self-determination. A primary function of my role as a social worker is to advocate strongly on behalf of my clients. Sure. Is that better? Sorry, we have a height differential here. I believe my role as a social worker is really to act as a strong patient advocate. This is a law in California, and I really want to ensure that our patients have equal access to utilizing this law.
Height difference. As a nurse, I have been witness to some very difficult deaths, both professionally and personally. And after taking this job 8 years ago and hearing our patients ask and inquire about the end of life medication, it's clear to me that it is important as a nurse to be able to educate and advocate for our patients. So patients have the right to know about what all their options are, and this is a legal option in California. So it is important that I know all of the information so we can educate patients and their families, and then they can make the decision that's best for them.
Thank you both. Before we move on, I just want to also acknowledge that this is work that I do not without ethical concerns. And curiously, the longer I do this work, the more I sometimes find myself living in the gray and having questions about some difficult cases that come up. And we want to make sure that there's plenty of time for rich discussion today, so we can talk about all of the nuances of this care that we provide to our patients. We have no financial conflicts of interest to disclose. We have a few learning objectives for today's discussion. First, we'll spend some time talking about the history of medical aid in dying and End-of-Life Option Act legislation statewide, nationwide, and internationally, and how this impacts the care that we provide here at UCSF. We'll then use a patient case to identify some important clinical pearls that we want you to keep in mind, as well as some special circumstances that you may encounter in your clinical practice that can be important to know about ahead of time. And finally, we'll touch on some future goals for this work. What is medical aid in dying? It was captured nicely in this 2020 article as a medical practice in which a physician provides a competent adult who has a terminal illness with a limited prognosis with a prescription for a lethal dose of a medication at the request of a patient, which that patient intends to use to end their life. It's important to know that there are many terminologies that are used for aid in dying practice, including the End-of-Life Option Act, or EOLOA, which we'll use heavily throughout this talk because this is the name of the legislation here in California. Aid in dying, or AID, physician-assisted dying or death. Death with dignity is a common phrase that you'll hear in advocacy communities. Physician-assisted suicide, and euthanasia. I want to make a special comment about these last two terminologies. First, euthanasia is death by a lethal injection. This is strictly prohibited in the United States. So when we talk about medical aid in dying, we are not referring to the practice of euthanasia. Physician-assisted suicide is also not the preferred terminology, and we would encourage all of you not to use this when you're talking about medical aid in dying. Aid in dying is a hot topic, not just here in the United States, but also internationally. There are currently 11 countries outside of the US that currently allow medical aid in dying in certain forms. Each country has its own details and policies regarding what is permissible. And I will note that in some countries outside of the United States, euthanasia is legal. And in some countries, a patient is not required to have a limited prognosis. Neither of those things are true here in the US. Currently in the United States, MAID is allowable in 12 states and jurisdictions, including Washington, D.C. It was first passed in 1994 in Oregon, and most recently became legal just last week in the state of New York. There's active legislation on many more ballots nationwide, and so this is an actively evolving area of practice. As in the international picture, there are details and discrepancies between some of the laws that you'll find in various states. Here in California, there were several attempts to pass aid in dying legislation before it actually became law. The first such proposal went on the ballot in 1992, and it failed as it only garnered 46% of the vote. There were 3 subsequent attempted efforts at legislation, which also failed between 1999 and 2006. And in October of 2015, the End of Life Option Act was signed into California law. As a result of this law, the first EOLOA workflow went live at UCSF in June of 2016. In January of 2022, important modifications were made to the law. There were several changes, but the most important one to be aware of from a clinical standpoint is that the mandatory minimum waiting period between the first and second requests was shortened from a minimum of 2 weeks to 48 hours, which had a major impact on our patients' ability to access this care. As a result of these updates to the law, it was an opportunity for us here at UCSF to undertake a comprehensive review process and quality improvement process around how we approach EOLOA workflow and policy here at UCSF. And so our policy revision committee undertook this process between January and July of 2022. Since then, we have been creating ongoing updates to our EOLOA patient and provider facing resources. We've been dedicated to educating our community and continuing to improve the feasibility and quality of this process. I want to take a moment to just highlight our interdisciplinary End of Life Option Act Policy Revision Committee members. These incredible colleagues worked very well and amazingly together to update every aspect of our EOLOA care and policy here at UCSF between January and July of 2022, and we're incredibly grateful for their service. So what's required to actually be eligible to pursue EOLOA in the state of California? First, a patient must have a serious life-limiting illness with an estimated prognosis of less than 6 months, according to 2 physicians who evaluate the patient. They must be at least 18 years old. They have to have capacity to make this medical decision. They must be a resident of the state of California, and they have to be able to self-administer the medications via an enteral route, so specifically by mouth, feeding tube, or rectally. This is a retrospective chart review study that was published in 2022 that gave us the first look at how MAID care is being carried out nationwide. Between 1998 and 2020, they identified almost 8,500 patients who received the MAID prescription, and of those, about 5,300 who died by ingestion of this prescription. As you can see from the figure here on the left side of the slide, the use of MAID is increasing nationwide in every state where it's permissible over time. What they found when they looked at the patients who tend to use this intervention is that patients tend to be older adults. They tend to be heavily non-Hispanic white, slight prevalence towards a male population, heavily college educated, and they primarily have a cancer diagnosis as their qualifying diagnostic category. The California Department of Public Health also closely tracks EOLOA care statewide. Between 2016 and 2023, about 6,500 individuals received an aid in dying prescription. Of those, about 2/3 died with ingestion of these medications, and the vast majority, 91.3%, were receiving palliative or hospice care at the time of medication ingestion. As you can see from the figure here on the right, the use of MAID prescriptions here in the state of California is also increasing year over year. As is the case with our nationwide data, in 2023, we found several parallels. 883 patients in the state of California died with ingestion of MAID medications. The median age was 78. These patients were heavily non-Hispanic white, about 50% male and female, heavily college educated, and the vast majority were connected to palliative care. Cancer remains the most common category for a qualifying diagnosis, with nearly 2/3 of the patients who pursue this care. Although among the population that pursues aid in dying for neurologic illness, ALS is overrepresented, with about 58% of the patient population in this category. I think these data really highlight some major equity concerns that we have as a community about our patients' ability to be educated about and access this care. And this is a major goal of our team to continue to improve in the coming years. Dr. Brian Anderson is a researcher here at UCSF who worked with us on the committee to improve EOL-away care. He and his group led a research study of 100 patients who pursued EOL-away care at UCSF between 2016 and 2020. And they found some really interesting observations. Of the factors that contributed to our patients' decisions to pursue the End of Life Option Act, they found that a steady loss of autonomy was the reason most often cited by patients for wanting to pursue aid in dying care. However, there were other factors as well, including poorly controlled symptoms, loss of control of bodily function, or a perceived loss of dignity, as well as an inability to enjoy activities that were previously meaningful. Of those 100 patients, 26 were deemed to be ineligible to receive the aid in dying medications, and there were several reasons for that. As you can see over on the left side of the figure, the most common reason was that the patient died while waiting for the medications, 34.6%. It's important to note that this occurred primarily in the first iteration of the law, when the mandatory minimum waiting period was 2 weeks between the requests. We are still working with our data core team to update our data here at UCSF, but we anticipate that many fewer patients will die waiting for this care. However, this is an important figure to point out, because we do encourage you, if this comes up with your patients in a clinical setting, to think about referring them early, to talk with a participating provider about this care, and to assess eligibility, just like we think about with any other form of advanced care planning. There were a subset of patients who ultimately declined to move forward with the process. There was another subset who lacked functional or neurologic capacity to move forward with the aid in dying medications. There was one patient who had a remote history of a suicide attempt. There was an old policy here at UCSF that initially prohibited any patient with a prior history of suicide attempt from pursuing the aid in dying process. That is no longer a policy here, and our committee recommended that that policy be discontinued. And it's important to note that none of the patients in our sample lacked psychiatric capacity to pursue aid in dying due to an underlying mood disorder, because this was very influential in our policy recommendations as well. We are just beginning our work with the Department of Medicine Data Core to provide updated data on all aspects of aid in dying care. So we'll have to come back in a few months and present our updated data to you all. But what you can see here from our very preliminary search of the electronic health records is that, as is the case statewide and nationwide, we see a steady increase in the number of End of Life Option Act related discussions that are happening with patients here at UCSF between 2020 and 2024, including projections for the remainder of 2025. Thanks to the work of our committee, we have many excellent new resources that we want you and your patients to be aware of so that you can turn to these when aid in dying comes up as a question with your patients. Most importantly, we have a fantastic new website that contains both patient and provider facing materials that we encourage you to check out and share with your patients. We also have a brand new live referral to EOLOA care in Apex, which is a fantastic tool to help your patients get connected with participating providers and providers who can assess whether or not your patient is eligible for aid in dying. And that's for both patients with cancer and with other conditions. We also have an Apex Smart Set that's embedded within Encounters that contains many resources at your fingertips within the electronic health record, including physician-facing resources, patient-facing resources, an updated medication order set, and additional information, for example, to connect patients with our community partners. In addition to that, we have several HIPAA-compliant, secure digital versions of the required EOLOA paperwork that are now available on Apex as well. And with that, I'll turn it over to Teddy for our patient case.
Can everyone hear me okay? Okay, cool. So we really want to ground all of this important information in a real life patient case. This is someone who I met a few months prior to his admission. He is a 59-year-old cisgender gay Latino male. He lives in the Pack Heights neighborhood of San Francisco. His main social supports are a small group of friends, and he has 2 siblings who live out of state. His primary income is from disability, and he has Medicare and Medi-Cal insurance. He has a pretty significant medical history. Most notably, he has metastatic pancreatic cancer with evidence of widespread recurrence, and he's presenting to the ED with a few days of obstipation and vomiting, and he's found to have a malignant small bowel obstruction. He's previously expressed interest in the End of Life Options Act process prior to his admission, and he's already initiated that process. And you're meeting with him during his admission. So we're going to revisit this case throughout the next few slides as we continue to discuss the End of Life Options Act process and how the process worked out for this patient. But before we revisit our patient, we're going to go through some of the steps in the End of Life Options Act process. First and foremost, this is a patient-initiated process. We as providers can always offer the End of Life Options Act as an option, but the patient should voice interest before we explore those steps with them. If you don't participate in this care and a patient voices interest, you don't need to provide education about the End of Life Options Act, but you do need to refer to a participating provider. Once the participating attending is identified, that person can discuss the law and the steps in the process. This education can also come from any member of the interdisciplinary team. We really want to encourage our IDT members to have these conversations as well, including, our social workers and nursing colleagues. And once the patient decides to pursue the End of Life Options Act, the patient will need to make 2 formal requests to the prescribing physician, and those requests must be 48 hours apart by law. The patient also needs to submit a written attestation requesting the End of Life Options Act, and that form should also be uploaded to the medical record. A consulting physician will also need to confirm their prognostic eligibility and interest in the End of Life Options Act. And it's important to note that the prescribing and consulting visits do not need to happen sequentially. They can happen in tandem in any order. And once all of those aforementioned steps are complete, the attending physician will then prescribe the medications once the patient has an ingestion date in mind. And lastly, the attending will upload all of that relevant documentation to the medical record and submit it to regulatory affairs as well. It's also important to note that provider participation is completely voluntary, and that applies to every member of the interdisciplinary team. Here at UCSF, we're so appreciative that so many departments support patients through the End of Life Options Act, including the Oncology Social Work Department that I'm housed in. And we value you wherever you fall on the spectrum of participation. If you're interested in participating and getting credentialed in the End of Life Options Act process, you can reach out to our resident expert, Dr. Bell, who's sitting over there. And it's important to note again that non-participating providers are required by law to refer patients to a provider who does participate in the End of Life Options Act process and to make note of that request in their chart note. Okay, so back to our case. So since the admission, his small bowel obstruction has been resolved with medical management, but he remains at pretty high risk for recurrence. He's declined further cancer treatment, and his main goal is to return home on hospice so that he can complete the End of Life Options Act process. And you find out during the admission that the consulting visit has not yet been completed. So I want you to imagine how you would proceed if you were caring for this patient. Depending on your level of comfortability, a myriad of thoughts might be running through your mind, right? Should I panic and ignore their requests? That's very normal. This is a very new process for so many people, and it's antithetical to what some people hold so dear about medical practice. Should you place an urgent consult to the palliative care service? Or should you place an APEX referral to the End of Life Options Act? All of these thoughts are totally normal, but we don't want you to panic. So we're going to talk through what the next steps and the referral process should look like so we can normalize it for all of you. First, before anything though, we really want to attune to the needs of your patients and express empathy and concern. You're facing a patient in distress who's asking for help more than anything. And many patients talk around the issue and are nervous to broach this topic with providers. So you might need to clarify what they're asking for. I might say, it sounds like you're experiencing a lot of physical and emotional pain. And I'm hearing that you're asking about medical aid in dying. Would you like me to refer you to someone who can talk with you about this process? Really, the best thing that we can do is to reassure our patients that, support is available. So this is the process itself that we'll walk you through now. Say you get an urgent End of Life Options Act request and you're working inpatient. That should prompt you to place a referral to the palliative care service for consult, or to reach out to the EOLOA medical director, Dr. Bell, and they'll work in tandem to find participating providers to connect to your patient. If you're working outpatient, you can submit a referral in APEX to the End of Life Options Act. And that will prompt, the End of Life Options Act medical director to assist in providing or assigning a participating provider. So let's wrap up our case. So thankfully, the consulting visit was able to be completed during their hospital stay. It's important to note that while most of these steps are completed outpatient, the consulting MD visit can happen during a hospital admission. The patient was discharged home on hospice. The outpatient palliative care provider prescribed the End of Life Options Act medications. He was unable to afford the medications himself, so we really had to rally his support system to help him pay for these medications up front. We'll talk more about insurance coverage for this in the next couple of slides. Oops. And the medical team arranged for rectal medication administration because it was safer than oral administration. And the patient died peacefully at home with friends on his own terms. So with that, I'll turn it over to Eve.
Thanks, Teddy. All right, make this low enough. Okay, so I'm going to talk about the actual details to the medications. So on the right-hand side of the screen, you can see that it is listed what the end-of-life medications are. And a patient needs 2 antiemetics an hour before taking the end-of-life meds. And then the end-of-life meds are a combination of digoxin, diazepam, morphine, amitriptyline, and phenol. And you can see from the list of medicines, these are very high lethal doses. And this is referred to as DDA-MPH, this combination of medications. Medications arrive as a powder, and a patient or their family caregiver have to mix the medications with 2 to 4 ounces of liquid and consume it in less than 2 minutes. And this is because patients fall asleep very quickly, so it's important they're able to drink it all in less than 2 minutes. The medications are expensive. They're about $750, and they are not covered by insurance. Medi-Cal will cover these, but the pharmacies that we work with, you have to pay for them up front, and then patients can apply for a reimbursement. We work with a small number of compounding pharmacies in the Bay Area, and they will ship these medicines, FedEx them to anywhere in California. And like Dr. Bell said, these medications are available on Apex on an order set. The Academy of Aid and Dying Medications have worked incredibly hard in trying to find the best combination for patients that is both well tolerated and that works quickly. And they have done so much work, and I recommend looking at their website because they are a leader in the importance of this combination of medicine. And what they found is that this medicine, DDMAPH, they studied 604 patients. And with those patients, 79% of patients died within less than 2 hours. So a patient takes the medicine, they quickly fall asleep, and then they stay asleep in a coma. And 79% die within less than 2 hours. But you can tell from this slide that 2% of patients took 10 to 19 hours to die. So we want to make sure that we counsel patients and families that although we expect patients to die quickly, it might take almost up to a whole day, but they will be asleep and it will be peaceful. The next thing I want to talk about is a lot of the lessons that we've learned working in end-of-life medicine and doing this work to different lessons that we've learned and special circumstances that we want to highlight that might come up for you. Unstably housed patients may qualify for EOLOA ingestion in certain facilities, but please know for the most part, most facilities will not participate in having patients ingest the medicine at their site. Certain patients with substance use disorder may qualify for higher doses, and Dr. Bell and the EOLOA medical team are always available to consult about these patients. For patients who can't afford the cost, sometimes we're able to work with the pharmacies to at least reduce the costs for some patients. And the EOLOA patient attestation, the form that the patient needs to sign, is available in all languages, and really important that a patient signs the form in the language they prefer. So talking about non-oral medication administration, Teddy talked about his case. So patients have to be able to self-administer. They can drink the medicines in a cup or through a straw. Somebody else can actually hold the cup for them. Or they have to push the medicines through the feeding tube with their own hands, or have a rectal tube placed. and they have to be able to push the plunger to the rectal tube. For rectal administration, a skilled clinician has to be available to help them with this procedure. And we in the EOLOA medical team this sometimes takes additional time, and we can help support arrange for this. It is not the law, but we highly recommend that hospice is on board when a patient decides to ingest the medicine. And this is so important for multiple reasons. One is this is an expected death at home. So patients it's best to have hospice, so it's calm and it's an expected death. And the other thing is that hospice, although they often can't be in the room when a patient ingests the medicine, they can be on site and be available to be a support for families while the patient is asleep and waiting to die. And thirdly, hospice provides bereavement care for families. So they will be able to receive bereavement after their their loved one dies. There are some insurance barriers to having hospice and working with us at UCSF. So we ideally want patients to complete the whole EOLOA process before they enroll in hospice. Of course, if this isn't possible, we can try to work with some of our community partners and talk to them about how they can help provide this care. But ideally, a patient will complete all the steps at UCSF before enrolling in hospice. In the outpatient palliative care clinic, I work a lot with patients with ALS. And as Dr. Bell said, ALS seek EOLOA at higher rates than the general population. And what we've learned from working with our patients with ALS is that they have to have, like everyone else, a prognosis of less than 6 months, which is usually determined with an FVC, forced vital capacity, of under 30%. And so patients, when they're inquiring about end-of-life meds, they have to make sure they have the prognosis of less than 6 months, and at that time, demonstrate that they can self-administer medications, either by drinking them or pushing their feeding tube. And because they have ALS, sometimes they aren't able to push a feeding tube, or sometimes they're not able to swallow. And so some of our patients do lose capacity to do this before they're prognostically eligible for EOLOA. And this can be extremely frustrating, disappointing for patients, and is important to counsel patients and families about this. Another group that comes to us inquiring a lot about EOLOA are patients with dementia. And this can be Parkinson's-related dementia, Lewy body, Alzheimer's. And unfortunately, these patients are going to lack the mental capacity to ask for EOLOA by the time their prognosis is less than 6 months. Patients often think that they can sort of put in their advance directive that at the time that their prognosis is less than 6 months, they want EOLOA, but they can't do that. So often we're breaking bad news to patients and need to talk to them about other options for them and their families. This is a current frontier for some organizations in the United States and abroad to talk about how patients with dementia could access EOLOA. A very few of our patients in our clinic have decided to opt to go abroad, where the prognosis requirement is not less than 6 months, or some have decided to pursue voluntary stopping eating and drinking. Just to touch a little bit more on the formal mental health assessment, like Dr. Bell said, so from 2016 to 2022, our patients were all required at UCSF to undergo a formal mental health assessment. And because of our research, it was found that 0 patients lack capacity to go forth with EOLOA due to a mood disorder. And in 2022, the Universal Mental Health Assessment was discontinued here at UCSF. However, a prescribing physician can always request a formal mental health assessment. And that's recommended for people with unclear decisional capacity, history of serious mental illness, severe subjective mood distress, or really any clinical concern that the prescribing physician has. The law states that this has to be completed by psychiatry or psychology. Breathe.
Thank you, Eve and Teddy. So to wrap up today, we just want to touch on some of our future goals for our team's work in this arena. Over the next year, we'll be partnering with the Department of Medicine Data Core team to optimize tracking of many EOLOA care metrics across UCSF with the intention of continuously improving access to care, the quality of clinical services, as well as opportunities for research in this space. We will also be collaborating with our sister sites at the General and at the VA and community organizations that we partner closely with, including By the Bay Health and others, to ensure that our patients who are anywhere within the UCSF network are receiving excellence in this arena of care. And we have an ongoing strong commitment to improving our clinical care, really working on enhancing equity for our vulnerable patient populations who are seeking this care, and research in this space. And in future years, we're also hoping to work towards a formal interdisciplinary consult service for the End of Life Option Act. That's a slight expansion from what we currently offer. So with that, we'd like to thank our many colleagues and partners for making this work possible. And thank you all for the opportunity to present to you today. And that wraps up our talk. So we look forward to discussion.
Are you all I'm going to sit up here for a little Q&A. Thank you all. That was so comprehensive. And as I found myself writing down questions, I found you answering them. And so I really appreciate the case-based format and helping educate us about how we can be good stewards of the law and the resources at UCSF. So I was really curious. It sounds like both from the perspective of changes to the law and changes to what we've put in place at UCSF, we've really been adapting over time, and that this has been an ongoing, process to try and find that balance between ensuring patients are knowledgeable about the steps they're able to undertake and, putting appropriate safeguards in place, yet really balancing that with patient autonomy. So I'm curious, have we gotten that right? Like, are we at a place where we're like, everybody feels really comfortable with that? Or is there a new, what is the next frontier? Is it ALS and dementia, and have other states taken that on? Or are there differences in the law in other states that you would like to see adopted here?
I mean, I guess what I think within our palliative care clinics, the outpatient clinics, I think we're doing a great job. I think the 48-hour waiting has really changed things for patients and has made it more available. I think that we do hear stories from either providers at UCSF, but a lot of providers outside of UCSF, where there's a lot of misinformation. Often patients are calling us sort of urgently, worrying, I was told this will take 1 to 3 months to complete, things like that. So I definitely think that we need to continue to educate. So when patients inquire about this, it's an open door and not a closed door. And I do still feel that some patients are getting both misinformation or just really came to us in a circuitous way. So that I definitely think we can work on.
I think I'll just add to, there's still a huge financial barrier to so many patients being able to access this resource. And I feel like that is the next frontier that we really have to conquer, is making sure that anyone can access these medications.
Thank you both. I totally agree with what Eve and Teddy said. I think we've made great progress in this arena statewide and also at UCSF. I have huge concerns about the inequities of care in this field, and that is something I think we're personally committed to as an organization and as a team, to ensuring that we're breaking down those barriers for our patients who are more marginalized and vulnerable going forward. I think in terms of, I love the word you used, adapting, Michelle, because I think that that really highlights what is so fascinating and unique about this area of practice. It is an area that really straddles the line between legislative policy, clinical care, and advocacy. And it's fascinating actually to attend any of the national conferences in this space because you really get to meet such a wide array of interesting individuals who are engaged in this work and who come at it from different vantage points. For me as the medical director here at UCSF, when I think about providing this care, I think about providing it in a gold standard way that is incredibly safe and effective for our patients and our providers. I do think that there are providers and advocates in this space who are thinking more about the frontiers. And I respect that and I want to follow along with them. I have some concerns about where some of the care is going, both in America, but also certainly internationally, around issues like being able to provide aid in dying for patients who lack a limited prognosis, for patients who may not have a terminal illness at all, for patients who may lack capacity. And I worry greatly that when we slide into those spaces, especially in places where this care can be provided via lethal injection, we become quite at risk of disproportionately offering this service to the most vulnerable members of our society as a substitute for the social determinants of health that our patients really need to thrive. And we see some evidence of this happening in places like Canada. So I truly believe that aid in dying should be offered to our patients to help them avoid a death that's filled with suffering from a terminal illness, not to help our patients avoid suffering that is somewhat unavoidable in the process of living life. Because I do believe that no life is free of suffering, and it's incumbent upon us in the healthcare field to try to alleviate the suffering that our patients encounter from social determinants of health and also from having an inadequate community support.
Well said. Thank you.
Hi, my name is Teva. I'm a medicine resident. Thank you for that very eloquent answer, all of you, and Dr. Bell in particular, talking about your concerns internationally and in other states. Do you have any ethical qualms with how the system works in California, and what policy changes would you recommend to address those?
Thank you, Teva, for that question. I think that my ethical qualms are really in the space that I just highlighted, which has to do with equity of access. And I think it is very fascinating to watch how legislation gets translated into clinical care policy on the ground. And that's been a really interesting part of this process for me and for our team, partnering with our community partners and our sister institutions to see how have they done it, and also how have we done it here at UCSF. And as you can hear, that's really evolved over the last several years. And so sometimes I worry about some of the variability in terms of how the legislation is being implemented and carried out on the ground. I think my primary concern is about equity of access and barriers to accessing this care, as I highlighted a moment ago and as we talked about in our discussion today. But in general, I think we've been moving in the right direction here in the state of California, and it's a continuous process of improvement. So I'm really pleased with some of the changes that were made to the law a couple of years ago. Anyone else want to comment on that?
I just want to say that, I think within our palliative care clinics, we're pretty, as much as you can determine someone's less than 6-month prognosis, we really try to make sure that both the prescribing physician and the consulting physician agree. And often these are diagnoses that aren't, they're a little more nebulous. They're neurologic diseases that are complex and not that common maybe. And so I think that, I think we do an amazing job here at UCSF, really, with this is what we can do and this is what we can't do. And that we can't give you, prescriptions if your prognosis is not less than 6 months. And I think there's a lot of agreement amongst our group about that.
I think I'll just add, it would be nice if California could evolve and allow for more on-site ingestion at hospitals and SNFs. It's considering like the cultural considerations of dying at home and, our unstably housed or unhoused folks who want to utilize this. It can be very challenging to find a location for them to ingest the medication.
Thanks, Teddy, for adding that. I totally disagree, and I was about to mention that as well. I think this is a major concern. Agree. Oh yeah, okay. Agree. We're very simpatico up here. And the other thing I'll mention is that there are patients who have specific disabilities that unfortunately functionally impair them from being able to access this care. And that is a major concern that I have, that unfortunately at this time we're not able to overcome in certain cases because of the limitations according to the law.
Hey, I'm Maggie. I'm on the hospice. Thank you. That was excellent. I wondered about costs and access. So $750 is a one-time thing. I guess you apply for the reimbursement after you're dead. Makes no sense to me at all. But does insurance, Medi-Cal, Medicare, does it cover the visits with the EOLA OA providers? Because it's also presumably quite expensive.
And if you're in hospital.
Right. Yeah. And why can't we do it in the hospital? You just can't do it in the hospitals?
Well, two-part question.
Multiple questions. So many amazing questions here. Thank you, Maggie, for holding our feet to the fire. So according to the law, there's actually no legal prohibition on completing these visits in the hospital. So I want to name that and acknowledge that in certain cases, that may actually be the most appropriate course of action. And anytime that's coming up for you, we would encourage you to reach out to me or to the team through the mechanisms that we described in the talk to get support around how to execute these cases. In general, we prefer not to carry out the prescribing physician visits and prescribe the medications when our patients are hospitalized, because it can be very difficult to provide the continuity of care that is essential for patients between the time of discharge and time of medication ingestion. And it's really important to check in with the patients within 24 hours of medication ingestion to ensure that they haven't developed any contraindications to moving forward, namely neurologic contraindications, so loss of mental capacity, and bowel obstruction are the two things that we worry about the most. So if we have a provider that is willing to do that follow through, there could be some circumstances in which we would, allow these steps to unfold in the hospital. But that can be.
This is like visits and prescriptions, but not taking the medication. Just
correct. Okay. So speaking about facilities, I share, and I think Eve shares Teddy's concern. Right now, it is prohibited to ingest the aid in dying medications on UCSF's campus. This is something we continue to work with leadership around, but this is the current policy by UCSF Health Leadership, and we honor that policy at present. It is also important to note that we have amazing partners in our hospice organizations around the Bay Area who are rapidly expanding the services that they can provide to patients. And our preferred hospice partner, By the Bay Health, now can conduct the prescribing visits and the consulting visits and can carry out this care for patients who are enrolled in their care. And we have some other partners that we work with as well. So that would be another reason to reach out to our team to get guidance and support around that. In terms of the cost of the visits, the short answer is yes, these visits are covered by insurance. So in general, that is why we actually encourage patients to try to complete these required visits upstream of hospice enrollment, because it can be much more difficult to ensure that visits are covered by insurance once the patient has enrolled in hospice care. So all of these efforts are designed to minimize the cost to our patients. You point out a really great question around reimbursement after death and what a strange issue that is. Again, we are committed to working with our patients who are vulnerable and marginalized and have limited resources to reduce the cost upfront as much as possible. And we do have several compounding pharmacy partners that are willing to do so in these cases, which we really appreciate.
To do with the facilities question, years ago, I was involved in a case where a patient was requesting EOLOA, couldn't do it at home, and was not a SNP or any other facility that could do it. So he actually enrolled at the Zen Hospice Center, and we were able to administer the medications and give them. Now, I don't think Zen Hospice Center exists anymore. Are there any facilities like that UCSF could?
I had a patient recently, I'll answer the question. I had a patient recently who was admitted to Mission House, which is a house associated, similar to Zen Hospice, is associated with By the Bay Health. And so was able to be admitted there, and By the Bay Health, who administers hospice in that facility, was able to. So we do have some, like a small window where that might be possible.
Yeah. I'll just add the hospice houses can be cost prohibitive for our low income patients. It is an out of pocket cost. So again, that speaks to the income disparity in being able to access this law. Some SNFs in the Bay Area will allow ingestion on site, but they're few and far between. And as we know, getting Medi-Cal beds at SNFs these days is really hard. So,
I also just wanted to say that we've had patients who live in assisted livings. So they live in their own apartments in assisted livings. And when they've asked about this, they're told they cannot ingest these medications on site. So it's really complicated for patients and their families when they're, this is their home. Maybe they've lived for 5 years and, they're not able to do what is really under the law.
I love everything that everyone said. And I think it highlights just like a really global challenge that we face in our society across every aspect of medical care, which is that money opens doors, and our patients who don't have it often get worse care and have less access to what they need. And so unfortunately, this area of practice, it shares some of those same realities. And we want you all to know that it's really our North Star, that our patients come first, and that we're extremely dedicated to improving equity in this aspect of care for our patients, along with everything else that we do.
Thanks. Hi, my name is Mosi Williams, social worker up here in hematology. Well, thank you guys for your talk. And my question was around the discontinuing of the assessment, mental health assessment that was used for patients in terms of eligibility. And just a question, insurance question was, did different insurances require that based, in terms of eligibility, or was it just across the board discontinued by the state?
Or by UCSF?
it was a UCSF policy to do the mental health assessment. It wasn't a part and isn't a part of the law. It was an extra safeguard that UCSF put in place when they initially rolled it out. We found that it was a huge barrier and delayed patients being able to access the medication in a timely manner. So now it's optional. So if there are concerns about capacity or if there's a serious mental health condition, they can be referred to psychiatry or psychology. But unfortunately, at least in the cancer center, we have a part-time psychiatrist who's in office one day a week at the cancer center who is doing all of these assessments. So as you can imagine, there was around like a 3-month delay in getting these patients the medications that they needed. Wonderful.
Well, I think we are at time. So please join me in thanking our 3 panelists. I know I speak for all of us when I share my appreciation for sort of demystifying the End of Life Option Act for us, making it feel much more accessible to us and by extension our patients, and highlighting some of the complexities and challenges of the current law and the realities we face as we strive to provide access to this needed service across the board for our patients. So thank you so much.
Thank you so much. It's great to be here.